we need to evaluate for these patients. One is the considerations for surgical aortic valve replacement in small aortic annuli, that I don't think that they should be much different from the TAVI. These are my disclosures. So first of all, we should come with a definition that what is small aortic annuli. Because indeed, if we take a look at the definitions that have been used so far, it will be those that wouldn't accommodate a prosthesis size larger than 21 millimeters. And also, it has been defined as an aortic annulus smaller than 23 millimeters or smaller, measured with echocardiography or intraoperatively. So that has not changed much during the years, but what has changed is the way we assess the aortic annulus. We have now CT more oftenly used, and the measurements are more accurate than with two-dimensional echocardiography. And intraoperatively, what we don't see is how is the interaction with other structures, such as, for example, the mitral valve, anterior mitral leaflet, or the contraction of the ventricle, that can give us also clues on what are the reasons for increased gradients. In terms of frequency, we know that between 22 and 44 patients that have an aortic stenosis, they may receive a prosthesis 21 millimeters smaller in the United States or Europe. And particularly in our area in Europe, this fact is 7 times more frequent in southern countries than in northern countries. And we have to remember that, for example, for Asians, they have a much smaller aortic annulus as compared to Europeans, and therefore many of them will enter in the definition of a small annuli. Is this for them a small annuli? I don't think that that has been perhaps studied. And as I said before, the way we measure now, perhaps we have much more accurate measurements. And this is how we used to measure. This is 2D echocardiography, depends on how we measure the annulus. We can have even aortic valve area that is different, while now we are much more used to three-dimensional techniques such as TOE or CT. And it's important also to remember that a small annuli or small aortic root also goes with a small aorta, and here there is a pressure recovery phenomenon that is much more pronounced, so we can make that these patients have much smaller aortic valve area for the same, with higher gradients when they have smaller aortas, and this challenge the diagnosis, as we could see in this already all published study. So for those patients that have small aortas, be mindful with the gradients that we measure on echocardiography. Who are the patients that present a small aortic annuli? A little bit what the case what was presented. Most of them are women. They have higher surgical risk. They have small body surface area. They have obesity with a body mass index above 30, atrial fibrillation, chronic kidney disease, and other comorbidities such as type 2 diabetes. And they are very symptomatic. Whether this is related to aortic stenosis or other comorbidities is sometimes difficult to discern. But these are more or less the same predictors of prosthesis-patient mismatch later on. You can see in this meta-analysis that those factors that are age, female body surface area, NIA class 3 or more, hypertension or diabetes or renal failure are associated with a more frequent patient prosthesis mismatch, and then bioprosthesis. But many of these studies were surgical studies. Compared to transcatheter valves, the presence of patient prosthesis mismatch or severe patient prosthesis mismatch is an effective orifice area below 0.65. This is the definition of prosthesis patient mismatch, but severe if it's less than 0.65. That is more frequent in surgical prosthesis, either stented or stentless bioprosthesis. With transcatheter valves, this is less frequent. And in terms of outcomes, the risk of having a patient prosthesis mismatch or the outcomes of SAVR and TAVR in a small aortic annuli, so you can see that is much larger for SAVR than for TAVI, but there are no differences for TAVI regardless of which is the type of valve that we use. Is this related with patient prosthesis mismatch? The relationship is not completely clear. Some studies have assumed that it could be related to that, but some others don't. And this is another case similar to the one that has been presented. Look at the small ascending aorta. This is a bicuspid aortic valve in a patient that had already an intervention because a subvalvular membrane and a Kono procedure, and eventually the valve was competent and was not changed, but now she comes with symptoms with an annulus that is 294, and here we need to consider again the risk of patient-prosthesis mismatch and even the occlusion of coronary ostia. So this is the schema for the VIVA trial, for example, that was led by Josep Rodés Cabau, and trying to define which are the patients that go for TAVI or for SAVR. And for those that have an annulus smaller than 21 and they have low risk, they recommend SAVR, and intermediate risk, in principle, TAVI, and some others we could consider even SAVR in some selected patients. With the new guidelines, this perhaps would have changed, and even the low risk would consider for TAVI. And in terms of how to follow up these patients when they have a small valve, be mindful that echo can lead to higher gradients because of the pressure recovery phenomenon, and that with echo you will have always those higher gradients as compared with invasive measurements. So before you name or indicate that a valve is not working properly, if it's small, try to do an invasive measurement to make sure that this is really dysfunctioning. Because then the valve-in-valve procedure, you need to take into account again the prosthesis patient mismatch and the risk of coronary osteocclusion, and consider that even though you may open the valve, you can still have increased gradients with echocardiography. So for me, the considerations for SAVR in a small aortic annuli, to say that a small aortic annulus is not infrequent, and challenge the diagnosis even of aortic stenosis severity, either in native valve but also in prosthetic valve. And the risk are prosthesis patient mismatch, the challenge in the diagnosis of prosthesis dysfunction later on, and you have to think about some subsequent interventions and the lifetime management of the patient. Thank you very much.